Infectious hepatitis is an inflammation of the liver driven primarily by 5 specific hepatotropic viruses. Despite originating from entirely different viral families, these pathogens converge on the liver to trigger a powerful inflammatory response. This shared biological target creates a nearly identical acute presentation. Regardless of the specific virus, patients typically present with jaundice, right upper quadrant abdominal pain, and hepatomegaly. These uniform acute symptoms make it difficult to distinguish between infections that resolve on their own and those that lead to chronic liver failure. To predict clinical trajectory, we categorize these viruses by transmission vectors, enteral and parenteral. Enteral transmission via the fecal-oral route typically results in an acute, self-limiting disease. Parenteral transmission through blood and bodily fluids carries a high risk of chronic infection and oncogenesis. Identifying the specific viral strain allows clinicians to project the patient's biological timeline and the likelihood of future organ failure. The first cohort includes hepatitis A and E, which utilize the fecal-oral transmission vector. These viruses are primarily spread through water contamination and inadequate sanitation infrastructure. This chart reveals a challenge for infection control. In hepatitis A, peak viral shedding occurs 2 weeks prior to the onset of jaundice. 1 week after jaundice appears, the viral load drops and the patient is no longer infectious. Pediatric presentations often lack typical symptoms. Young children frequently present anapteric and may exhibit diarrhea, while adults more commonly experience constipation. These infections do not establish a chronic state. They are entirely self-limiting and only require supportive therapy to manage symptoms. In the enteral cohort, the primary risk involves the silent window of peak infectivity, enabling rapid epidemic spread before a single patient shows symptoms. The clinical trajectory changes with parenteral vectors, such as percutaneous needle exposure, permucosal fluid contact, and vertical transmission to infants. This group is defined by hepatitis B, a DNA virus, and hepatitis C, which utilizes an RNA genome. Chronic infection triggers a destructive histological cascade. Portal tract inflammation leads to hepatocyte necrosis, which is eventually replaced by a webbing of thick, fibrous tissue. This biological cascade leads directly to cirrhosis and hepatocellular carcinoma. Hepatitis B follows an inverse age symptom rule. Perinatally infected infants rarely show clinical signs, yet face the highest risk of establishing a lifelong chronic infection. Conversely, adults who acquire the virus often experience severe acute symptoms, but rarely progress to a chronic state. Hepatitis C is distinct for its high rate of chronicity. Over 80% of those acutely infected will develop a chronic infection lasting decades. Because parenteral viruses cause silent cellular remodeling over many years, staging the disease requires specific serological markers rather than physical examination. Staging a hepatitis B infection is difficult because patients are often entirely asymptomatic while the virus is active. This matrix identifies infection stages. HBsAg indicates current infection, while HBeAg signifies active replication. The core antibody timeline reveals exposure history. Anti-HBc IgM marks acute infection, while IgG persists. Anti-HBs indicates clinical immunity. Using these, we isolate clinical profiles. An acute infection is confirmed when both the surface antigen and the IgM core antibody are present simultaneously. The second profile is chronic infection, defined by the persistence of the surface antigen and the IgG core antibody, while protective surface antibodies remain absent. Finally, immunity from vaccination. These patients test positive exclusively for the protective anti-HBs antibody. Because vaccines contain only the surface antigen, core antibodies always test negative. This matrix is the only reliable way to determine if an asymptomatic patient has cleared the virus or is at risk for end-stage liver failure. Hepatitis D is a structural anomaly that is biologically unrelated to the other 4 viruses. HDV is an obligate parasite. It cannot infect cells without the assistance of hepatitis B surface antigens providing its outer envelope. This restricts it to parenteral transmission routes. If a patient with chronic HBV develops a sudden, fulminant acute hepatic flare, it suggests the introduction of this second pathogen. This is why an HDV superinfection is so dangerous. It can rapidly turn a previously stable chronic hepatitis B case into sudden, catastrophic liver failure. All suspected hepatotropic infections are diagnosed by combining liver function tests with specific viral serology. In these cases, ALT levels rise significantly higher than AST, often reaching 2,000 units per liter during the acute phase. Once the specific virus is identified, the goals of treatment differ. For the enteral viruses, A and E, management is limited to supportive care while the infection resolves naturally. In chronic parenteral cases, the objective is the sustained suppression of viral replication to prevent the development of cirrhosis, using interferons or nucleotide analogs. The first line of defense against these outcomes is immunization. Universal vaccines for hepatitis A and B offer high-level protection, stopping the transmission cycle and preventing the establishment of a chronic state. Hepatitis C lacks an available vaccine, meaning prevention relies entirely on universal precautions and strict blood safety protocols. Patients with chronic hepatitis B or C must be vaccinated against hepatitis A. A secondary acute infection on a scarred liver significantly compounds failure risk. Managing infectious hepatitis requires an understanding of each virus's long-term biological trajectory to prevent an acute-on-chronic catastrophic failure.